So today it's really an honor and a privilege to have with us one of the most outstanding cardiovascular surgeons in Southern California. Dr. Dewan is a cardiothoracic surgery. He did his general surgical residency at the University of Ottawa. He did his residency in general surgery at Harbor UCLA Medical Center and the University of Texas in San Antonio. He did a fellowship in cardiovascular surgery at Loma Linda University. He is a board certified by the American Board of Surgery, by the American Board of Thoracic Surgery. He's a fellow of the American College of Surgeons. He currently is a professor of surgery at the UCLA School of Medicine and the assistant chief of cardiovascular surgery there. His research focus has been on minimally invasive valvular surgery, atrial fibrillation, coronary artery bypass surgery, endocarditis, and valve repair and replacement. He's been published in multiple professional journals, and he's going to talk to us today about what's new in cardiovascular surgery. Please welcome Dr. Dewan.
Good. So thank you all for coming, and I think the weather was kind of okay, right? Better. I was afraid that this event is going to get rained out. So, my talk, Dr. Lawton has been so kind with this introduction, and my talk is about advances in cardiothoracic surgery. But whenever we talk about advances, it's good to know what are we advancing from, right? So let's go back to the 1300s. And this is in England. And there was this society, the Worshipful Company of Barbers. They were actually barbers who were, quote unquote, the first surgeons. They were the technical aspect, they were guided by monks, because the monks were forbidden by the church to touch blood and stuff like that. So they enlisted, they said, who can we enlist to be surgeons, to operate on things and to cut things out and stuff like that. So they enlisted barbers. So it was the first surgeons were actually barbers. And that's one of the reasons that in England till date, if you're a surgeon, you're addressed as Mr. So-and-so. When you're a physician, you're Dr. So-and-so. So still surgeons in England are addressed as Mr. So Mr. John Hunter is one of the fathers of modern day surgery. But modern day, what does it mean? 1700s. So this is when he was one of the first few people in Scotland. He's a Scottish gentleman who actually went into and looked into, cataloged and dissected animals and had different specimens all collected and published a textbook. So he's known as sort of the father of modern day surgery. So, and then cardiac surgery was even much later than that. So we're looking at in the 1800s where, the military and different events in the military are the ones which stimulate a lot of advances for that time. So it was missile wounds in the heart which were repaired and fixed, and that's what started the thing that, yes, you can do cardiac surgery. And there was this World War II surgeon, Harkin, who prided himself that I removed 134 missiles from the mediastinum, meaning the chest portion of the body. Then came, this is actually the first operation done, and this is a little baby. They have an abnormal connection between the biggest blood vessel leaving the heart and the biggest blood vessel that goes to the lung. So one has oxygen in it, the other one has no oxygen in it. Babies have this little connection which keeps them alive when they're in the mother's womb, but when you come out, you don't need that connection anymore. So that thing has to close. So, and sometimes it doesn't close, and that makes these little neonates and these little babies very sick. So this is what they did. They clipped this little blood vessel, and they have this blood pressure tracing. You know, like you have, all of you measure your upper number and the lower number. So this is when they clipped it, suddenly the lower number went up, you know, right as the clip was going on. This is the way they used to monitor it. And this is Dr. Blaylock. I think in the United States, he was one of the true pioneers about heart surgery. And I don't know if any one of you had the opportunity, or if you guys should. There's a wonderful movie. It's called Something the Lord Made, which is how at the time when the church sort of forbade you to operate on the heart where the soul rests, to someone actually taking the initiative and saying, no, I want to save these little babies who are condemned to die. And this Dr. Thoracic was a cardiologist there, and then they invented this operation where this is the biggest blood vessel that's leaving the lungs. I mean, leaving the heart for the lungs. So this is blocked. So there's not enough blood which can go to the lungs. So you can't. These babies were blue because, you know, the blood was just, you know, couldn't get oxygen. And they connected another blood vessel onto that, and they sewed it on. And it was actually pretty dramatic. It was in a real operating theaters why they were called theaters, because people would sit all around them and watch them do it. And how they operated on this little baby, how it's a movie. If you guys ever have time, it's Something the Lord Made. You know, it's a phenomenal, very good movie. Then the surgeon in Minneapolis, he said in order to operate on these little kids, you know, they would die because, you know, you stop the heart or you manipulate the heart. So what they did is they connected the mother to the child, and so that the mother would be the heart and the lung that could pump the blood into the baby. And that's how some of the operations were done. And I actually met, I know he's an oncologist, a cancer doctor, who is probably one of the smartest people I've ever met. And he tells me that I was one of his Lilly High's quote-unquote, at that time, experiments, and he was a tremendous success because people said, oh, the brain is not going to work, this and all. He said, look, my brain is as sharp as anybody else's. So then, you know, there was this interest, how to do heart surgery. So the industry got motivated, and so they built this little machine, because when you operate on the heart, you have, you know, the heart has stopped and the lungs are stopped. So what is it? This heart-lung machine was built. Look at these big machines that had to be used in order to operate on one patient. To now this point, this is a current-day heart-lung machine. So things have progressed from where you had to be on like tippy toes in order to reach part of the machines to where our perfusionists, they're called the perfusionists, are the people who man the heart-lung machine. That they can just sit there and, you know, just dial a few knobs and everything is taken care of by technology. So that's where we have come. And now there's robotic heart surgery going on. Now surgeons actually are not even next to the patient. So the surgeon is sitting on the side. I mean, they wear still the sterile uniforms, but you don't even have to. You could be next door. You could be drinking coffee, and the robot, which is controlled by the surgeon, is operating. So so this is like an illustration. So, you know, there's a surgeon is far, there is the nurse, which is by the patient, and there's an assistant surgeon who's standing here too. And this is what the surgeon is seeing. So this is a real-life view of cardiac surgery. So the person there is not the primary surgeon. The primary surgeon is sitting very far there. So this is just some illustrations I wanted to show you how technology has changed in the recent years. That instead of the big incision, you can make these smaller little holes and perform surgery. And this is the conventional bypass incision, while the robotic-assisted one has these 3 ports and a little incision here, and that's all you need. So the robot, actually, this is the dexterity, and they show it that it's like in the movies. Whatever movement you do, the robot can emulated, and with much more precision. It eliminates fine tremors and, you know, the shakiness and all. It just fixes it all, you know. So, and then we have come to the point we have artificial hearts now. So if somebody's heart, for some reason, has reached a point where it can't function, you can implant a heart. And you know this person, our former vice president, he's one of the poster boys of who had an artificial heart till he found another, you know, donated live heart. But prior to that, he lived for a period of time on the artificial heart. And so this is like what some of the devices are. So this is the artificial heart, which is plugged in at a couple of places in the heart. It is connected to a battery, and this can control it. And these are the battery packs, and the motor is all in here. And this little device can sort of replace the heart. Not forever, but for months at a time. So this is an actual patient. You know, this is how they look. They have like almost like a little bit bigger than the microphone I have, and with a couple of battery packs. And all these devices are just getting smaller and smaller as technology develops. So look at them. You can live a fruitful life with, but sometimes the irony of this thing is, you know, a lot of these people don't have a true pulse. So when you check their pulse, they don't have a true pulse because this motor can't give that big beating like the heart can do. So it is continuous flow. It alters a little bit. So you know, if what are our classic things? There was this person alive, oh, check the pulse. Well, this person doesn't have a pulse, but he's walking around and talking and like, you know. So that's, now this is one. We're going to talk about a few different things. And one of the things I'm going to go in greater detail about is aortic stenosis. This is a very commonly affected disorder, which the US population is very prevalent. And it is sort of either underdiagnosed or undertreated. So what happens is that this valve, this is the aortic valve. This is the valve, which is the biggest valve where the blood comes out of the heart, out into the aorta. So this prevents the backflow of the blood back into the heart. So once it ejects, the heart doesn't want that blood back. So, but that valve, unfortunately, with time, like, you know, people develop blockages in blood vessels in their body, in their legs, in their brain, in their neck. You can also develop these calcium deposits in the valve. And that makes the valve is unable to open all the way. So that's what's called stenosis, aortic stenosis. And it's a very common disorder. So what are some of the signs and symptoms? Although this is a potentially life-threatening disorder, but the symptoms and the diagnosis is very easy. That's the irony about this. That, believe it or not, over 65, 7% of the US population has aortic stenosis. So if we statistically look in this room, if the people over 65, 7% of them will have aortic stenosis statistically. And it affects men more than women. And 80% of the people who have symptoms, which we'll talk about, are usually men. So women have less symptoms, but they do have the stenotic valve. So what causes this stenosis, this blockage? Most common is age-related with the calcium deposits we talked about. Sometimes if you had an infection in your childhood, can potentially lead to the increased amount of deposits and stenosis. Rheumatic fever, which is not that common in the United States, but in the world is actually the most common reason for people to have aortic stenosis. So if anybody has an immigrant background and stuff like that, they may have aortic stenosis from rheumatic fever. And some congenital, meaning that's the way they were born, predisposes them to develop this. So like we looked at the valve right here. It has 3 leaflets, right? This is 1 leaflet, we call them. This is the second one. This is the third one. If you're born with, some people are born with 2 leaflets. And those patients or those people are more likely to develop a problem with their aortic valve. So what are some of the risk factors for, we were talking about it earlier, that how do you determine whether this person is likely to have it or this person is likely to have the disease? If they're older, if they're male, if they have high blood pressure, if they're smoking or have a significant history of smoking. So if you've smoked like for 40 years and quit last year, unfortunately that doesn't suddenly eliminate the risk. The risks stay on. So, and if you have high cholesterol. What are some of the symptoms? The reason I talk about that, if even one person here who's not been diagnosed because of this talk takes the initiative and pushes someone if they have the symptoms, or one of your friends or family members, I think the purpose of this talk is served. Because that's why I want you guys to listen. These are some of the symptoms. So people can have chest pain-like symptoms, like burning, discomfort, squeezing pain in the arm, neck, jaw. They can have fainting episodes. That is also one of the symptoms that you could have aortic stenosis. They feel winded and tired when they're walking or taking a flight of stairs, something they didn't before, and now they get short of breath. They feel dizzy. They feel that my heart is racing or is irregular, and I feel these palpitations. These are some of the symptoms. So it doesn't mean, I'm not there to panic you. If you have the symptoms, you have aortic stenosis. Absolutely not. But if you have several of them, then that just begs somebody's attention to make sure you do not have aortic stenosis. So how is it? You don't need fancy machines and all. We do all the tests. All you need is the stethoscope to diagnose it. So this is what the classical teaching, when I teach medical students, is, nowadays with all these technologies, and you've probably seen your physicians, a lot of them don't even use their stethoscopes. A lot of them okay, you see them in and out, and we're so dependent because we get an ultrasound of this, an ultrasound of that. We don't need the stethoscope, but this is one disease process where you put the stethoscope on the chest, and there's a sound the heart gives, which is classic for aortic stenosis. So that is, it's such a easily diagnosed, and then it can be worked up, because not all aortic stenosis is bad, because you can have mild amount, moderate amount, for which nothing needs to be done. So severe also, it's not everybody with severe stenosis needs something. It is just a selective group of patients who have severe blockage of the valve that need something done. So you start with the stethoscope, then they do the ultrasound of the heart, which is the echocardiogram. You get the EKG, and then eventually, finally, you get the angiogram done to confirm that you have this valve which is bad now. So the reason it's important to diagnose is this is, as you age, once you have symptoms at this point, then this is the survival. Then the survival just takes a huge dip. So that's why it's very important, once you have these symptoms, then you need to diagnose it, because then it is like a time bomb. Because the survival, once you have these symptoms of chest pain, of syncope, which is like these fainting spells, and heart failure, which is the shortness of breath, once you have them, only half of the people who have the symptoms will survive 2 years. So that is why it's important to diagnose it, and if needed, treat it. So look at this, 5-year survival, right? I mean, we're all afraid of breast cancer, lung cancer, prostate cancer. But believe it or not, people who have this, like breast cancer, 23% survive 5 years, average. Some people survive much more than that, but this is the average. Lung cancer, average people survive 4 years. But believe it or not, the 5-year, 4% survive. 5-year survival of aortic stenosis is only 3%. So if you look at it, having it is so important to treat it and address it. Now, if we could skip this one. Now, as we're talking about the newer technology, classical, the operation was this valve. We had a cow or a pig valve, which is a tissue valve, or there's a carbon fiber valve, which you take out the old valve surgically and put the new valve in. That's the classic treatment. But nowadays, there's an alternative where you can potentially avoid open heart surgery. Now, what I'm trying to tell you, convey that the message of this talk is, as far as aortic stenosis, it's not to tell you that surgery is not as good as the one we're going to talk about through the groin. So this is the valve which is put in patients through the groin without having an incision in the chest. It is done for high risk or patients who cannot get surgery, and some intermediate risk. Because the reason for that is that the complications, despite of it being less invasive, doesn't mean it has less complication. So the complications are almost similar, and as a matter of fact, some of the complications, like people can get a stroke with heart surgery and a stroke with this, the stroke rate is actually higher if you go in through the groin as compared to open surgery. So although the complication rates are similar, but it is easier to tolerate. So patients who are basically high risk, or we call them high to intermediate risk, are potential candidates for this therapy. And this is what the procedure entails. So this is, it's like a stent. It's the stent with this is all cow pericardium, meaning the lining of the heart of cows is stripped of all, fat and everything on it. They pick the most even thickness of the lining of the heart of these cows, and they sew it on to this metal frame. And that's what gets deployed, meaning placed in place of your existing valve. This is a depiction where, this is where the previous valve was, and this new valve is put in, and the old valve is crushed onto the side. And we have some videos which we'll show you. Would it play by itself, or do I have to play it? This is actually the procedure being done. So I'll walk you through it. So this is the heart, and then they'll walk into this is the valve. You see how tight it is? It's not opening up. It should open all the way up to here. It's the calcium that's preventing this valve from opening. So we go in from the groin. This is in the groin, the blood vessel. The wire goes all the way up, goes across the valve. Then this is a balloon, because it's very tight, so we open it up to accommodate the valve. You stop the heart, and boom, you open it up. And see, it's a little bit more open. You take the balloon back out. Now you put in the valve. So this is put in a little sheath, which is placed first, and the valve goes up. So it goes around the aorta. This is the big blood vessel. That's the big curve. Goes in its place. We stop the heart again briefly, and then boom, there's the new valve. And I think at the end they show you how much more open it is going to be. See, as compared to that previous opening, now it's open all the way. So that allows the heart to breathe again, you see? See the dramatic difference from where it was before to now. So, and then this is the next video. which is, so that one was through the groin. But another one, you can go in through the chest too, through a little incision. Some people have bad blood vessels and blockages, and you can't do it through the groin. And this is the same thing, with a little incision on the side. Same thing, that's all the calcium, and the valve is not opening. So this time you go in through the tip of the heart. You see, you go through the tip up. So the other way, you cross the valve with the wire. You put in that sheath through which the valve will come up. This is the sheath. That's the balloon. You crack it open. And then you'll see the valve coming up. There's the valve. There we go. So all that requires is a little incision on the side.
What is the life of the valve?
The life of this valve, the company tells you it is about 10 to 15 years. But the first generation of valves, which is not that long ago, put in 3, 4, 5 years ago, the average only lasted 5, 6 years. So they said that they've made changes. So that is one of the things, the downsides of this valve, that it is not tested whether it'll work that long. While surgical valves have shown to work 15 years or more. So that's why I said, this is not a replacement therapy as of today. It is another tool in the armamentarium which you can potentially use if you are a high surgical risk. This is the same picture of the deployment. This is the actual what we see when we do it. That other one was a cartoon. You see, that's where the valve is being deployed. You see right here. So this is what we see. It's like an X-ray. It's a fancy X-ray, which is a continuous X-ray going on. So that's what we see in this. You guys want to watch this one again, or is that pretty? This one came pretty quickly about. Let me just see. There it is. See, that's what we see. The valve gets deployed. The old valve gets crushed onto the side, and these metal surrounding the valve are the one which helps it attach so it doesn't fly off.
What kind of metal?
It's a special nickel titanium alloy which is used pretty much in all surgical cardiac devices. So this is some of the people which predisposes them, instead of having open surgery, may want to consider this one through the groin or through the smaller incision in the chest. So depending on age, if you are frail, meaning you have a hard time walking, and because then recovering from heart surgery is significantly harder. Like if you're on a walker, you can barely walk from here to the door, and that's if you know, these are some of the factors. If you had radiation, for example, for breast cancer in the past, and then if you have bad lung disease and stuff, which may, so it's not having one of them makes you go through this catheter valve. It's having a combination of these factors. So now the other thing, so this was the aortic valve, right? The other newer things which are there nowadays is how to treat mitral valve. That's another big valve, this is right in the middle of the heart. And that valve in a significant population is leaking, which causes heart failure. And then the legs get swollen, they have water in their lungs, and they develop heart failure. So ideally for them, medicines are started first. Medicines work in some patients, some don't, and then they need surgery. Well, like we talked about, some people are too high risk and they cannot withstand surgery. So what are their options? 10 years ago, there was no option. That's like tough luck, you know. You either had surgery, well, you're not a candidate for surgery, so you've run out of options. But now there is something, it's called the MitraClip, which has come out. So this is this little clip. So the mitral valve is, we'll see it in some picture. It's unlike the previous valve, which had 3 leaflets, this one just has 2 leaflets. And when the 2 leaflets can't get together, that's when it leaks in between. So what this clip does, it actually at one point in one leaflet and the other point in the other leaflet, it just clips them together. So what it does is it reduces the amount of leakage. It doesn't eliminate it, so that's why it is only reserved for patients who are not candidates for surgery to improve their amount of leakage they have in the heart. So that's their MitraClip. So these are these little sharp, you know, they're like prongs, which one attaches to the front, one attaches to the back of the leaflet, and that's how. And this is such a small thing. This is you know, a dime, and look how small this device is. That's just put in, and same thing, it can be put in through the groin. So these are the 2 leaflets I was showing you. You see, this is one leaf. This is a cut, a cross section, so it's cut across the heart. This is one of the leaflets. This is the other one. You see, it's not able to come together. So what this clip does, it clips in the front to the back, but it only does it in one small area. So because if you close it, I mean, if this clip was covering the entire area, it'll close the valve, and that's horrendously bad. So you do it in one. So then the presumption is that once you close this, at least the amount of leakage would reduce, and you would not longer be in heart failure. So this is how it's done. It's you know, same thing. It's done through the groin. You go up the heart, then you go across. There is a septum. You go across, and then the damaged valve is here, and then you apply the clip. And so this is one of the newer technologies for the mitral valve nowadays that's around. Next thing is another common disease process is atrial fibrillation. So there's a lot of patients who have, you know, are on blood thinners, and those have its own risk attached to it. So there are actually now a lot of therapy which can be done, and so this is what atrial fibrillation is. So this is a normal heart rhythm. So this is the heart, cross-section of the heart. This is the right side of the heart. This is the left side of the heart. These are the upper chambers. These are the 2 lower chambers. The heart rhythm starts right up here. It gets conducted across, goes across from the upper chambers to the lower chambers, and gets all around. Well, atrial fibrillation it's these abnormal pathways. So not only does the heart rhythm start here, there's all these other places where the rhythm starts and it loops around, and that's why people have this palpitation and a fast heart rate, because there's a lot of areas where the heartbeat is originating from. So what you can do for that is ablation, which is basically burning different tissues of the heart to eliminate all these areas which are generating a rhythm. So you burn this area so that it cannot do that anymore, and then you get back into the big boss. This is the pacemaker of the heart, which is the only one which can give the rhythm. So so like, you know, these are all these points where abnormal rhythms can be anywhere. So that's what your goal is with the treatment. Now that is done 2 ways. You can do it, and they've been treating it and talking about it for the past 15 years, what's better, what's not. But the bottom line is, the best as of today is if you do it in combination. Go do it from the groin and to do it surgically. That gives you the most complete and the best resolution of this atrial fibrillation. So, and surgery used to be like this big surgery. You cut open their breastbone and it's heart surgery. But nowadays you can do it with much smaller incision. Like this is a patient, look at it. This is all after surgery. He has these 3 little holes. On the right side, a couple of holes on the left side, and that's it. So it's no more cutting open the chest and a long recovery. You're up around walking and you go home in 2 days. So this is what the latest, greatest thing is. It's called the convergent procedure. So this is where the cardiologist and the surgeons work together. Each one of them does their part. Go ahead.
How do you know which areas to avoid?
So I will talk to you about it. Well, I could go in more details, but most of the atrial fibrillation, those foci we talked about, these aberrant pathways, 80% are around the structure called pulmonary veins, which is where the blood supply from the lungs goes back into the heart. So 80% of these abnormal foci, which are starting the rhythm, are around the pulmonary veins. So that is what you are primarily trying to eliminate. And then after that, they do these studies where they test what are the other areas could be, because 20% chances it could be elsewhere. So that's when they selectively can burn those. So that is what this convergent procedure essentially is trying to achieve, is that surgically you go in with a little incision below your breastbone. You go in, this is where the veins attach in the back of the heart. You go back in and you put these burns across. So this is the pulmonary veins. So there are 4 of them total, 2 from the left, 2 from the right. So they're coming in right here. So this is what you surgically can burn these areas, and then the catheter goes in from the groin and does the touch-up for the other potential areas, because 25% of them are not around the pulmonary veins, so they can burn those areas. So that's what the cardiologists do. The surgeons do one part, that works about 70–80% of the time, and then the cardiologists do the touch-ups. So, so now atrial fibrillation, like I said, it's a very common. I wouldn't be surprised if several people here have atrial fibrillation. What is the thing what people are afraid of, apart from the fact that they feel these palpitations? There's strokes. So stroke is like the biggest fear. That's why you're placed on these blood thinners. Now, why does the stroke develop? The stroke develops because fibrillation means the heart beats like this. Fibrillation is like the quivering. So when it quivers, basically the blood doesn't move that well. It stagnates. Whenever blood stops, it clots. So that's why clots develop in the heart. The area that develop most commonly is a little outpouching the heart has. So a lot of the area is smooth and big, so the chances is blood is going to get pushed ahead. But there is this little outpouching in the heart, which is called the appendage, and that's where the clots develop. So that's why they've developed this new device. It's called the Watchman device. So this it's like an umbrella. It's a filter, which actually gets placed from the groin. This is the appendage I was talking. The rest of the heart, things move along, but this is the outpouching where clots develop. So what this device does, it closes up this outpouching. So that is basically reducing your stroke risk. It doesn't eliminate it, but it reduces your risk of having a stroke. So that is the technology that's there right now. The last thing I wanted to talk to you about is aneurysms. So aneurysms are this blood vessels, the strength of the wall gets weakened. Because it's weakened with the blood pressure, it gets bigger and bigger and bigger. That's what an aneurysm is. You can have aneurysms of the brain, you can have aneurysms in the legs, arms, and one of the dangerous ones is having it in the aorta, which is the biggest blood vessel leaving the heart. So this is what we used to have to do for all these aneurysms. Look at this cut. You put them on the side, big operation, cut them all the way. We would push up. This is the lung being pushed up, and this is that big aortic aneurysm. Normal aorta should be like less than half this size, but it's all bulged up. But this is the operation we would have to do. This is like what we would put, this is the graft, which is an artificial aorta. We would sew onto the top, sew onto the bottom, and take out that aneurysm. Now this operation was a huge operation, and it's still being done because some patients do need this operation still. But you're looking at hospital for like 10 days, 7, 8, 9 days, recovery period. You look at this incision, you have to recover from this. That would take months on end. People would be miserable. There would be so much blood had to be given, blood products had to be given because you would bleed and you would not be able to clot. And that has now developed into, like, this is the aneurysm I was saying. So this is the big blood vessel leaving the heart. This is all in the chest. You see how it bulges out? So what we do now, you can have stents in it. So look at this. So the same thing, like the videos I showed you, these guide wires get put in over the wire, the stent, it seals it on the top, seals it on the bottom, eliminates the aneurysm. This is it. This is the kind of stent it is. And the stent is a little different than, it has these prongs on both ends, which help it stick on the top, stick it on the bottom. These are uncovered, while the rest of this is all covered. So that's what prevents the blood, because if you have a stent which can leak through, then you don't achieve anything. So this portion is all covered. From here to here is all covered, and just the distal, I mean the ends at this end and at the other end are the one where the prongs help the stent stick on to the blood vessel, the aorta. So this is an example. You see how the seal develops up here, and same thing. These are the two prongs, the covered stent, the big bulging aneurysm, which the danger of that is that it can rupture. And if you rupture, I mean, half the patients die. So this prevents that, but in a less invasive way. No more cutting open and 10-day in the hospital and 10% risk of not making it through the operation to like home the next day. So these are just different examples. So look at that. The same thing, what surgery would do, this is what open surgery would put the graft in. Now we go in through the groin and put the graft in without cutting the chest or anything, with just a little incision in the groin. So this brings to the end of this talk. So when we talked about how did cardiac surgery start, to like what is the future of cardiac surgery? We've gotten to this point, artificial hearts, valves through the groin, surgeons sitting right now in the corner of the room. Maybe in 5 years it'll be like the guy in New York is operating on the patient in LA, you know? We've gotten there, but what is the true purpose, and what is the future of heart surgery? It truly is only one thing. It is to develop therapies or treatments to extend human life and relieve suffering. So that brings me to the end of my talk. Thank you very much. All right, let's get to our second part of our program. I know I answered some questions, but it'll be good now because, you know, some questions, a lot of other people have the same question, so that'll help. Yeah. So who has a question? All right, let's start from this side and we work this way.
How close are you getting to doing TAVR for all patients, not just high risk? And will that be a good thing, because it's less recovery?
So the question is that the TAVR, which is the aortic valve through the groin or through the little incision in the chest, without the heart-lung machine and stopping the heart, how close are we to doing it for everyone with aortic stenosis? Okay. So the answer to your question is, it is an evolving process. It started, when I first started doing them about 4 or 5 years ago, it was only reserved for patients who are not surgical candidates. So we had to, as surgeons, write in the chart that this patient is not a surgical candidate, and then he or she can get that procedure. Then it evolved within a year to the point where, well, you can do it in high-risk patients. So high-risk patient is a patient whose risk of dying with surgery is 8% or more. You can do it in them. Now, as of last year, the criteria changed to intermediate risk, which is if your risk of dying with with an open heart surgery is more than about 3.5, well, it started with 4, but then they lowered it 3.5%, then you can be considered for a TAVR. So to answer your question, there is a trial already going on low-risk patients. So it will, it would be, everybody, I wouldn't be surprised, within two years or so, everybody would be eligible. But then the biggest question that will come into play though, yes, you can do it, but should you do it? Because the question of longevity has not been conclusively answered, meaning how long will that valve last that you put in through the groin? A surgical valve, they have studied, it'll last you 15 plus years. Will that valve last you the same time? Then, let's suppose it doesn't pan out that same time period, then the cumulative risk of having, because the TAVR can be repeated, so you put a valve in, it stops working 5, 6, 7 years later, you can put another valve into that one. But that is, the cumulative risk of 2 surgeries is much higher than 1 open surgery. So I think the data is still out there. It will get approved, I bet, within a year or 2. And the other big thing is the economics of it. The valve, the transcatheter through the groin valve, costs $30,000. The surgical valve costs $6,000, the cost to the hospital. So you're per valve already $25,000 behind the surgical valve. Now, I agree there's other costs, like hospital stays longer in surgical valves, blood usage is more, but does the cost gonna equilibrate? Well, right now, 2 companies only make that, the groin valve. There's another 3 companies coming out. So once there's competition, that people are predicting that will drive the cost down. And then when the economics of it and the patient safety data all pans out, that's when we'll reach the point where so I wouldn't be surprised if 10 years, 15 years between the costs going down and the valves getting better, that it will become, basically everybody will get it through the groin except people who are not candidates. So like if somebody in their 40s needs a valve, and if you start putting in those groin valves, then you're gonna be like tons of valves. So as compared to the mechanical valves, which are the carbon fiber valves, which last you your lifetime, they'll, so it'll become like, like what happens to open heart surgery for blockages. There was a time, all these people were getting open heart surgery. Now it's funneled down. Like most people get stents and only a few get. So I think it'll be sort of similar thing would happen to aortic valves.
Currently, this appears to be non-emergency, so what would be a procedure for a person to go through first as cardiologist and then recommendations for surgeons? How would that work?
For which procedure?
Any procedure, but
So
in general, how?
in general, obviously it starts with the primary care. So the primary carers need to have a reasonable suspicion or have ordered a test to diagnose whatever problem it is. Then it goes to the cardiologist, who makes sure that, hey, the heart problem you have, can that be fixed with medicines? And if not, then they say, oh, this needs intervention. Well, can that be done by the cardiologist? If that's something that cannot be done, they refer it to the surgeon. So we see patients much later in line, and except atrial fibrillation, sometimes I get referrals directly from primary care doctors, but for pretty much everything else, it comes through the cardiologist. Yes, sir.
AFib, lifestyle have influence on that?
It does, to the sense like your dietary habits. I'm sorry, oh yeah. So does, in atrial fibrillation, does lifestyle influence atrial fibrillation? Yes, it does. There's various components to it. So, like your dietary intake is a big one. That the caffeines, the chocolates, the nicotines, and all, they stimulate. All these stimulants can cause more incidence of atrial fibrillation. So, and then obviously if you include your compliance, meaning whether you take your medicines on time or regularly, stuff like that, so that affects whether you have it or not. And, yes, I mean, I think it, it does affect it, and that's something which is recommended to be modified first before embarking on surgical intervention.
On atrial fibrillation, why aren't all patients receiving an ablation procedure?
The reason for that is they're believers. The question is, there's so many people with atrial fibrillation, why isn't everybody getting ablated? Well, the big thing is they're believers and they're non-believers. So believers are people who think that yes, these interventions truly do help. The non-believers, which is still a significant number of people, saying that the chance of success is not that significant as compared to the risk. So, because if you look at the literature, the chances of you curing atrial fibrillation, that is the main goal. The secondary goal is if people who have atrial fibrillation will go back and forth, to reduce the number of times they go into atrial fibrillation, because they're uncomfortable at that time. So the primary goal obviously is to cure it, and the other one is to reduce the incidences. Well, these procedures will reduce the incidences at a much higher percentage as compared to curing it, meaning that your cardiologist is comfortable to take you off the blood thinner, which in reality is a very small percentage of patients can, it's no more like 80% people, 90%, some people say, oh, with my procedure, 90% people are cured. Well, are 90% off Coumadin? No, because I'm still afraid that they may have one incidence and stuff like that. So that is why it has, when I got out of training in 2005, the cardiac surgery volume was going down. And then I remember I went to this meeting in San Antonio. Everybody was talking about, hey, don't worry about open heart surgery, because atrial fibrillation surgery, there are millions more patients with it and it'll take off. But it never took off to that extent. So there's still very small percentage of patients who get ablation. And the ones who get ablations usually are, just because the way medicine is structured, they're done by one person. So either they're with the cardiologist or they're with the surgeon, and mostly with the cardiologist. So they don't get the comprehensive treatment. So I think as healthcare is evolving, where it's a team concept, it's not like I want to do it, or he wants to do it, or she wants to do it. I think the percentage of patients getting ablation will go up, and your results would be significantly better, which you can talk about it in the community. If you look at it, there's only one center in Orange County, for example, which promotes atrial fibrillation surgery. And there are like 10 heart surgery programs. So it's, the experience and the teamwork is very varied. So I think that's why people don't get this procedure, and a very small fraction of patients. A lot of people say, I don't want to go through this. I don't want, because there are risks associated with it. You can bleed, you can have a stroke, there are all these problems. So people say, no, I just take my Coumadin, I'm happy. I don't want to go through all these interventions and re-interventions. Especially if you're told like, oh, there's still a 50% chance you'll still be on Coumadin. So you don't have the incentive.
Some of the problems you showed, in fact, most of them seem to be caused by calcification in the heart and the vessels. Yet, many people, including old people, take calcium supplements or dairy. What's your recommendation on that?
So as far as calcium supplements, it's not the calcium that you ingest which goes there. It is basically a plaque what develops. It's cholesterol which truly starts it. That's the primary culprit. And once that cholesterol develops that blockage, calcium will go into it. So you could be nutritionally calcium deprived. That doesn't mean you will not have these problems. Because once you develop that plaque, it is just the course of the disease is that eventually calcium will go in there. So the intake does not. As far as dairy is concerned, Well, you'd have to ask a dietitian because there's various opinions about is it good, is it 1%, 2%, full, half, no. That's all like like in our house, we have 3 kinds or 4 kinds of milks, I think. We have some non-dairy milk like almond, then we'll have a full, we have a 2 and 1. I asked my wife, why do you have like 4 kinds of milk? Because this person likes this person likes. So I'm just telling you, in our own household of like 5 people, 3 kids and my wife and myself, we have 4 kinds of milk. So I don't know what's the correct answer.
That appendix you talked about was something new to me. Where is it located in the heart?
It's in the left atrium. So the upper chamber are the atria. There are 2. There's a right one and the left one. The left one is where the appendage is. There is an appendage on the right side too, but you see, the blood from the right side goes to the lung. The blood from the left side goes to the body. So the clots which are on the left side are much more dangerous than clots on the right side, because the left side will go to the body, and one of the first places as it leaves the heart is going to the brain. So that's why the strokes happen. That it's, once the clot or whatever calcium leaves the heart, one of the first places it's most likely to go is the brain.
During the valve insertion, you talked about stopping and restarting the heart. How do you do that?
Well, it's actually, I wanted to make it a little simpler. You don't truly stop it, but you induce sort of a rhythm similar to fibrillation. So fibrillation is like the beating, which the blood doesn't flow. So what you do is you have a pacemaker in the heart, and you crank it up to 180, 200 heart rate. So once it beats that fast, it is not able to eject blood.
Blood doesn't flow.
Right. So that's it. But I wanted to keep it instead of having to explain. So that's why in those pictures also you'll see it like all vibrating, the heart. It doesn't truly like just stop. And then for the stents, when we put these stents in the thoracic aorta, we give another drug. It's called adenosine, which what it does is that actually stops the heart or slows it down a lot. So if your heart rate is like 80, it can bring it down to like 20 or 30 for just a brief amount of time. So that's what we do. So everybody has their own ways. The reason the stents are started being done by vascular surgeons and cardiac surgeons, and the valves are done with the cardiologist and the cardiac surgeons. So the cardiologists find it easier to put a pacemaker in, while the vascular surgeons can't put a pacemaker and they don't want to call a cardiologist to do it, so they just pick the drug. So everybody picked their own modality, how to achieve the goal of, the goal is there shouldn't be a big gush of blood to displace the valve or the stent. So.
Question. When the mitral valve isn't working well, and the fluid gets out of the system into the lower chest cavity, how does that, what causes that leak?
So, see, the mitral valve is on the left side. The blood from the lungs flows into the left side. So that valve is leaking, so then there is backflow basically and back pressure on the lungs. The more then the blood gets retained in the lungs. The more you retain, then part of it seeps out. That's the effusion, that's the heart failure. So that's where the fluid seeps out around the lungs. So you have, first you have more water in the lungs. I'm sorry?
It gets out of the lungs then?
Right, yes, in the surrounding area, in between the chest wall and the lungs. And you have something called pleural effusion, which is a fluid collection. So that's all the back pressure from the leaky valve. Because the mitral, if it's working, there shouldn't be any back pressure on the lung. It should just empty. But now the blood suddenly have to deal with not only the blood that comes from the right side of the heart, but also the one that's back flowing from the left side of the heart side.
And the lungs therefore somehow let it seep out.
Yeah, they first get congested, sort of what we call vascular congestion, meaning they have more blood than they should have in them, and then eventually it seeps out. Any other questions? Oh, sorry.
Yeah, do you know what the latest research is on stem cells to improve or reverse heart failure?
To be honest with you, about 5-6 years ago, it was like the latest, greatest thing. And I remember being approached that, hey, we should start this study, and because theoretically it sounds like a great idea. So he's asking about stem cells. You know, these are cells basically which can become whatever they want to. So if your muscle is dead, they'll become more muscle. That's sort of the basic idea, right? These are baby cells which can grow into whatever they want to, or they can grow up into that. But for some reason, the studies didn't pan out that well. So it never became the accepted modality of treatment. But with the amount of money and research that is going into stem cells, I think it has a bright future. There's actually a lot of, you can tell where money is going into. And stem cell is a big one. Similarly, like, you guys have all heard about these chemotherapy, right? There used to be these toxic chemotherapy drugs. And nowadays you see all these Keytruda, this, that. These are all antibodies, right? And they're all antibodies. So that's enough. So these are the areas where I think the NIH is funding a lot of money, and I think there is promise. But as of today, it is not close, not even in the next 5 years, to like be an accepted modality of treatment.
Are they doing any surgery at UCLA?
The biggest one I think is at Cedars. Yeah, because the big heart failure group from UCLA went to Cedars about 6-7 years ago, and they were the transplant heart failure people, and they're the ones who do this the most, and I think they have the most prolific program, at least in Southern California, as of today.
One more question.
Uh-huh.
What's your thoughts about plant-based diets and the orange program and, for cardiac health?
I'm not an expert in that, and you can look at me. I'm not like a figure of health myself, despite of my wife. My wife sort of knows more about it than I do, because she tells me, don't do this, don't do that. And what I feel about Ornish is it's a failed diet. This diet has been around forever. It's not like something that just came up last year. It may be sold again, but it's like a repackaged thing which failed because it's so hard to adhere to. So that was its downfall, that it is so stringent that any diet that you can't sustain will not stay. So it's just being repackaged, resold. So what I tell everyone is adopt a healthy diet which you can maintain long term. And I can tell you from personal experience, I went to my med school reunion in 2011. I lost 45 pounds in, I think, over 6 months or so. And within 6 months of coming back from the reunion, I was back at the baseline weight. So I adopted a diet which could help me, but it just wasn't sustainable. So it's just hard. And I think whatever you can do, diet, and the key is exercise. What is the reason for exercise? 80% of, or more than that even, of weight loss is all carbohydrates controlled. But the exercise helps you by developing more muscle mass, and the muscle will eat up all the carbohydrates that you even end up consuming. So that's the principle of if you want to lose for a reunion, like a quick 20 pounds, just don't have any carbohydrates. That's the quickest thing. If you want to leave a healthy lifestyle, then exercise, develop muscle mass, and pick a diet which you can have, which you're not craving. I mean, for 6 months, I was craving, I'm telling you. I mean, I was cross restaurants driving down, and I was God, when can I have a piece of cake? And when can I do that? It just was not a sustainable, thing I chose to do. Yes.
A question on ablation to determine where it's really coming from. Basically, you don't ablate everything around there. Somehow you determine where you're going to ablate in that particular area. Is there something that generates a spark and receives the spark, or how is that done?
So it starts off by the presumption that most of the foci are around the pulmonary vein. So you do the pulmonary veins for sure.
100%.
Yes,
Okay,
right.
that's the answer. Thank you.
And then there's something called mapping. That's when they do the check the foci. Is there another foci somewhere else? And that's when they do the touch-ups or catheter ablated. The problem is if you do it all catheter ablated to get around the pulmonary veins and all, it's very hard to do it to get good lesions. So surgically, you can get a reliable pulmonary vein lesion. And all the other foci, which are potential sources, then can be mapped, and those foci can be burned selectively. That's why the approach should be together. The surgeons do one part, and the cardiologists do the other part.
Well, how do they map it to find out where it's coming?
They have these devices that they put in there, and it gets there, and it's put on the tissue, and this fancy map. I could have made a slide out of it, but I thought it would be too confusing. It actually makes like a picture, like a weird, colorful picture with different coloring in it, and then this is another foci. Let's burn that. So that's how you do it. So it's a mapping done. So the electrophysiologists, they are the specialists for heart rhythm. They are the only ones who can do the mapping. Surgeons can't do it.
These valves and the stents, they buy you time. But how many heart replacements are you doing now, and what's the list like?
So heart replacements? To be honest to you, most people, her question is the stents and all these surgeries, they buy you time, but how many replacements are you doing now? To be honest to you, the heart transplant volume is actually one of the lowest volumes of transplanted organs, because most of the things can be either fixed or temporized to the point where you won't need a transplant, because the heart and the lungs are sort of the hardest organ to get. Because when you look at criteria, they're from donors, right? And if somebody dies, so there's so many criteria for which you reject. So if anybody's blood pressure was a little low, if anybody had any history of high blood pressure, you can't have their heart, if had a history of that. So the potential donors, the donor pool is extremely low. And for unlike liver and kidneys, where you can have live donations, where people can donate part of their liver and donate one of their kidneys, there's nothing like that for the heart. So I personally think long term, like 15 years from today, it is the artificial hearts which are going to truly take that role as compared to organ donation. Because organ donation seems easy, but it comes with a lot of baggage. It is not an easy one to maintain. And then the criteria whether somebody is eligible, you have a long list of criteria that if you don't meet it, well, you're not eligible for a transplant.
Is it still worth it to have your driver's license say you're an organ donator, or that's coming not necessarily? So
this is what I heard. Okay. So my wife donated it because when she filled up my renewal form, she said, yes, he's an organ donor. But I think legally, you can't just go by that. You still have to ask the next of kin whether to take it. That may be a guide for the next of kin that yes, that it's okay to donate. But I don't think so legally. If your driving license is done, if that is the final word. If your next of kin says no, we don't want to donate my mom's whatever, then it's over.
Okay.
All right, everybody has to go to the jazz concert now, huh?
Dr. Lawton wanted me to remind you to go to Florentine's. So thank you very much, and I think everybody appreciates